lecture in this neuro theme is neuro prognostication. Do we need new metrics by Dr. Subba sir?
Thank you. Sorry again, bear with me for 10 to 15 minutes. So my topic is, do we need more metrics for neuroprognostication? So we know when it comes to metrics, people in the hospitals, they talk about the financial metrics, business metrics and all. But this is entirely different. We are talking about metrics in neuroprognostication. Do we need more? We have enough, right? So do you agree? Do you need more? Anyone say, you can raise your hands if you want more metrics for neuroprognostication. So we have enough metrics. We'll see what are the pitfalls of those existing metrics, and then we'll see whether we require more. I think some technical glitch, not opening. Huh? What happened? Okay, sorry. So we need metrics for neuroprognostication for predicting the neurological outcomes. The family, the caregivers will plan, they will have financial planning. They will see what to do. Long-term care units they'll be looking at, and then some interventions we plan based on the prognosis. If the prognosis is good, then we do cranioplasty, we do all the interventions, we continue in the rehab, they spend money. But if there's no prognosis, there's no point like continuing. And then especially in countries like low income and middle income countries, you create more patients in vegetative state, and then it's a financial burden for the society, especially after severe traumatic brain injury, severe stroke, severe like after post cardiac arrest. So a lot of clinical decisions, resource allocation, family discussion revolve around neuroprognostication. So currently we have some clinical tools like GCS, Glasgow Coma Outcome Score also, and then we have modified Rankin score, we have NHS for stroke, and then imaging modalities like CT, MRI to know any structural abnormalities. We have biomarkers like NSC, neuron specific analysis, and S100B, and neurophysiological testing, SSEPs, and then motor evoked potentials. So all of us know this is designed for paramedics, and then all of us know about the Glasgow Coma score, and we depend more on the Glasgow outcome score when it comes to the traumatic brain injury. But the trajectory of clinical examination, if you see, that is more important than any metric. The clinical decision is more important. If there's no breathing, pupils are not reacting, if there are no brainstem functions, this is not involved in the GCS. That's the pitfall. And if the brainstem is not functioning, then the prognosis is poor. And we look at the motor response. If somebody is localizing to pain, or if somebody is obeying commands, then they will have very good outcomes. And this is very subjective. When you are monitoring pupils post cardiac arrest or any traumatic brain injury, sometimes the pupils are, if you ask the nurse, some people say so sluggishly reacting, some people say not reacting, they say very small, sir, we are not able to appreciate. If you have an automated pupillometry, and then if it is consistently not reacting in automated pupillometry, because it is very sensitive for your pupillary size, and then the constriction velocity, dilatational velocity, and then we have a index, pupillary index, and then the false positive rate is 0. If the pupillometry, if the pupils are not reacting consistently for 2 to 3 days for a post cardiac arrest patient. And then we have a lot of biomarkers. So if you look at neuron specific analysis, which is done in few labs in the country, and in many hospitals in US, they do neurofilament light chain, that is NFL, and this is more sensitive, and S100B, and then we have glial fibrillatory acidic protein, and then we have a ratio between NFL and glial fibrillatory acidic protein that gives better prognosis. And then if you see the ROC curves for the both NSE and then NFL is a better predictor, because if somebody is in multi-organ dysfunction, the NSE is not a reliable marker for neuroprognostication. If you look at the post-cardiac arrest prognostication at different timelines, initially the clinical examination, And then we can use imaging modalities like we can use CT, MR, and then we use EEG. We use evoked potentials. When you do MR, if you look at that MR, there is cortical hyperintensities, and then if you look at the next film, and then you see hyperintensities in the basal ganglia region, and then you can see the hyperintensities in occipital lobes. If you look at the MRI, and then if you want to prognosticate, this MR can mimic even in if somebody is having posterior reversible encephalopathy syndrome, the occipital lobes are hyperintense, and you cannot really differentiate between post cardiac arrest, hypoxic ischemic encephalopathy, and metabolic encephalopathy in MR. So you need many metrics, not one metric will help you. And then if you look at the EEGs, and then if you look at, we have some EEGs, malignant EEGs, and then you see the burst suppression, and then you see the spike wave pattern, and then there the malignant EEG, then the patient's recovery is very, very poor. They don't recover. So you need EEG also for prognostication. And then if your EEG is showing spike wave pattern, and then there is some background activity, it is not flatline, then the prognosis is better. 50% of these people recover whenever it is Lance Adams variant. So recently we had one patient with post cardiac arrest, very poor prognosis. We were talking to the patient attendants. We did everything including neuron specific enolase, and then they wanted to take Mayo Clinic opinion for prognostication. They wanted someone else to say that patient has poor prognosis. So then we took the Mayo Clinic consultation, and then we were talking to them. So then we told we have done everything. We have done MRI, we have done neuro, we have done biomarkers and all. But the consultant, the neurocritical care consultant from there, he asked, have you done N20? They wanted N20. So N20 is also very, very important. So except N20, we have done everything. Then we told we'll do N20. We missed that N20. So in N20, you stimulate the median. Now after 20 milliseconds, you see some negative wave. That means the cortex is functional. And if it is not reacting, then again you have to repeat, you have to rule out the confounders, and then you have to repeat, and then it has false positivity rate is less than 1%. This is also very, very sensitive. When the N20 is absent, the prognosis is very, very poor. And for predicting in traumatic brain injury, we have different models. We have MRC crash model, we have impact model, that is international mission project for the traumatic brain injury, and impact prognostic models. We have taken, they have taken clinical things, and then they have taken imaging, and then they have seen evoked potentials, and then they gave a predictive model for traumatic brain injury. And so what are the limitations of your current metrics? So these are all static metrics, and then there is subjectivity in assessment. Glasgow Coma Score, it is inter-observer variability is very high, and then they have limited sensitivity, specificity, and then most of the metrics are population biased and developed validated for specific group of patients. And then the biomarkers, if you see the NSC alone is not reliable because it is falsely high during a patient with multi-organ dysfunction. You have to look at the serial NSCs, and then if you see the old American Academy of Neurology guidelines, if they say NSC more than 33 micrograms is a poor prognostic thing, but you have to look at the serial NSCs like your serial procals or serial pro-BNPs you monitor in your ICU. And the patients have excellent neuroplasticity. Some patients, they recover. That's why the Curing Coma campaign is very popular, because neuronal plasticity is very fascinating. But there are no metrics to measure the neuronal plasticity for these patients. And then when you have multimodal models, and then you can't integrate all your data into your multimodal models, and then there is no real-time monitoring. Nowadays, we keep a wearable, and then we send the patient, we monitor everything, but nothing for the neurological monitoring. No wearable can give you. So we need more metrics to address the limitations of the current tool. And so what are the emerging metrics? So in some centers, either neuro rehabs or in some hospitals, if the patient has severe traumatic brain injury, they do functional MRIs to look at the integrity of the tracks, to look to see the outcomes, and then they do diffusion tensor imaging. These are all advanced MRIs, and then these are very helpful in the prognostication. And then we have a lot of AI ML models for the prognostication, and EEG analysis by using AI models is more precise. And then artificial intelligence in neuroprognostications is really revolutionizing by analyzing the vast amounts of the data and identifying through ML and deep learning. So they gave the models. So and in different for different conditions they have given AI ML models with the deep learning algorithms. So one model in stroke outcome prediction, and then this is a FDA approved model. It gives by analyzing your CT reports, it gives what intervention it is required for this particular patient and what is the neuroprognosis. And we have similar AI based models in traumatic brain injury by looking by incorporating all the new AI models. They incorporate even functional MRI and then the diffusion tensor imaging, and then they accurately predict the neuroprognosis for these traumatic brain injury patients. And this is much more sensitive than any clinician or any one expert. So these models are very good. In post cardiac arrest neuroprognostication, again very very difficult. Which patient is going to recover, which patient is not going to who is not recovering. So we have they have incorporated mainly EEG into this, and then with imaging, and then they developed a lot of post cardiac arrest AI model for the prognostication. Again, this is very very sensitive, and then you can decide after this, you can decide whether to go aggressively or to talk to the patient attendants, and then we can talk to them about end of life if the prognosis is poor. And then we have a model for neurodegenerative disease progression like amyotrophic lateral sclerosis, or if you have a patient with Parkinson's, advanced Parkinson's, again they have AI deep learning. With AI and deep learning, they have models for different conditions, and then they can give exact neuroprognostication. And then, as I told, curing coma campaign is very popular. They say when the patient is in coma, don't leave them, and continue, and neuronal because of the neuronal plasticity, they may recover. They may come out of the coma after 6 months, after 1 year. So they say you have to continue up to 1 year to see whether the patient is recovering or not. But can we extrapolate to our country or any middle income countries where it's a huge financial burden on the family? So we have a model, AI based model for coma recovery prediction. This is also very useful, and then developed by the University of Cambridge. And then we have seizure prognosis in epilepsy. This is one area they're using wearables now, like when you use wearable for remote monitoring. So they have a wearable for EEG, and then you get EEG. This is like a lead free EEG, and then it can predict when the patient is getting seizure, and then with medication what is happening to the seizure. This is very good in predicting outcomes in patients with seizures. Pediatric neurology is again fascinating. Like a lot of people they recover because of the very good neuronal plasticity. And you see it like very severe traumatic brain injury in a pediatric patient. We generally get we used to get a lot of patients olden days because of the huge TVs. When they go and play with those TV stands, the TV used to fall, and then people used to come with severe traumatic brain injury. And I have seen in my experience these people had great recovery because of the neuronal plasticity. And then even after ischemic hypoxic ischemic encephalopathy, the prognosis is good for in the pediatric neurology. So there you need very good AI models to detect neurological outcomes. So what are the limitations of the present metrics? So there is no proper validation standardization for all these AI ML models, and then too complex, and then for multimodal integration, and then you need lot of technology, you need lot of data. All these are data driven, technology driven, and then yeah, at multiple layers the cost drivers are too high, and then it is going to be expensive for the patients. Ultimately you can prognosticate, but it is going to be very expensive, and then there are ethical considerations. So by using one new biomarker, you can't say that the patient has poor prognosis and then they take a call after that patient may recover. So there are a lot of ethical hurdles, and then you need a lot of collaboration. So not one metric will help you. It is always a multimodal prognostic approach. So you need good neurological assessment by a neurophysician or neurointensivist, and then you need good neuroimaging, CT or advanced MRIs or EEGs, again AI integrated EEGs, and then neuro biomarkers. NFL is a better marker than your neuron specific enolase. NFL or glial fibrillatory acidic protein is good. And then ultimately it is the clinical expertise. You are the one who is going to prognosticate by looking at all the metrics. Even if you have too many metrics, unless there is a clinician who is expert in neuroprognostication, so nothing can beat that clinician. Thank you so much.
Any questions for Dr. Subba Reddy on the two topics that he presented this evening? Thank you.
If there are no questions, sir, please wait on the dais. Madam, I like to felicitate Dr. Subba sir for his presentation from the Hyderabad ISCC. Thank you, madam, for helping us out in the 11th hour. So, sir, I would like to continue the chair the next session also. The next session will be early vasopressor in sepsis. Less is more. It is a try bit. The pro will be by Dr. Sunil Kumaran and the con will be presented by Nanda Kishore Jampala.
Thank you very much. Can I ask, I mean, before we start, late in